Hello, everyone. Thanks for coming and for the finals seminar this semester. It's my great pleasure today to introduce our dear colleague, Dr. Tormod Rogne. I try to pronounce it in the Norwegian.
I don't even know how to pronounce it.
So Tormod is an assistant professor here at the Department of Chronic Disease Epidemiology. He's perinatal epidemiologist with ongoing projects linked to exposure to high ambient temperature, air pollution during the pregnancy and some adverse pregnancy outcome, childhood health. So prior to joining Yale in faculty, he trained and worked clinically as a medical doctor in Norway, and he took his PhD and postdoc at the Norwegian University of Science and Technology. And before he became faculty, he was actually here as a Fulbright Scholar. So we have a lot of ongoing work. I want to mention that Tormod is also affiliated faculty for our Yale Center on Culture and Health. So we are very delighted to have him.
Thank you. Kind introduction. I'm just works. There we go. Okay. Yeah. Thank you for having me. My name is Professor of Epidemiology, and yeah, I'm trained as a medical doctor and a perinatal epidemiologist. So I think that my background entering the space of climate change and health research is slightly different compared with many. Hopefully that can shed some new, or hopefully we can sort of address some new questions with that background or not. But I do have a very I do have a passion for research on how climate change affects pregnancy. And for the reasons that we'll look at in a bit, I argue that this is a very underappreciated question, whether high ambient temperatures affects the pregnant population. So we've all seen headlines such as this and sort of get this impression that we're heading for a doomsday in the future. And the question is, how can we make sure that the pregnant population and the coming generations are as little affected as possible? And the structure for today's agenda is that we're first going to talk about the current literature on how extreme heat and high ambient temperatures affect pregnancy. And then we're going to focus on the final chapter on how exposure to high ambient temperatures during pregnancy affects offspring outcomes. And as you will see in a bit, I argue that there is currently very little research on this space, which is why I'm focusing on our project for this last chapter and focusing on other research groups' research in this first chapter. So in the first section, we're first going to have a look at the exposure burden to high ambient temperatures in pregnancy. And then we're going to look at the hypothetical biological pathways linking heat exposure in pregnancy to adverse pregnancy outcomes. And finally, we're going to look at whether the map fits the terrain and whether the epidemiological literature actually shows what it shows in terms of the link between high ambient temperatures and adverse pregnancy outcomes. For the final chapter, I'm going to talk about two projects that we have ongoing. The first one is on leukemia, and the second one is on offspring cerebral palsy. So, extreme heat in pregnancy. I just want to flag that I am going to focus on extreme heat, and I acknowledge that climate change is much more than just high ambient temperatures, and high ambient temperatures, of course, doesn't work in a silo or isolation. It has these interactive effects with air pollution, of course, and you have these distal effects or distal consequences of heat, such as drought and displacement, etc. But for this presentation, in order to fit it into 45-minute presentation, we're just going to focus on more the direct consequences of extreme heat. So, as you know, heat waves are increasingly common. So the black line here is the global average. And if we look at the pregnant population today compared to 20, 30 years ago, it's estimated that the current pregnant population is exposed to roughly twice as many heat wave days compared to 20, 30 years ago. And not only are the heat waves more common, they also are longer and they are more intense. And it looks like the heat waves are here to stay with us and are probably going to become increasingly worse for the coming decades. So the heat waves aren't going away. The question is, how do we deal with them? So this is really one of the key reasons why I'm so passionate about the topic of heat exposure in pregnancy, because I feel like this is a very underappreciated topic. So if we look at the official sort of governmental state guidelines in terms of identifying who is at risk at times of heat stress or in times of heat waves. If we look to Canada, for instance, we like to look to Canada often in admiration. Well, this time, not in admiration, because they have identified several vulnerable groups at times of extreme heat. All of these groups should be cared for in particular, but they have not identified the pregnant population. If you look to the UK, the same groups have been identified. Same thing in Australia. In South Africa, they have identified the pregnant population as a risk group. In the US, we actually have identified pregnant women as a group that is at risk during heat waves, and also the WHO acknowledged this. So this is just a quick look at what is sort of the official policies from these different countries. So I chose countries where it was easy to find available guidelines available to me in English. But the point is, if I didn't find, I mean, they might have hidden away somewhere deep in a data brief that the pregnant population is also vulnerable. But if I wasn't able to find it, the general population is also not able to find it. And sort of the official attitudes or the governmental attitudes of who is at risk during heat waves, of course, also will be reflected in the general population and what the general population thinks about who is at risk during the periods of extreme heat. So there have been several surveys. We're going to look at two of them. So in this first study, they interviewed passers-by in Lisbon and Madrid, Portugal and Spain, where only 6% and 5% of those who were surveyed identified the pregnant population as vulnerable at times of extreme heat. A similar survey was conducted in Georgia, Tunisia, and Israel, where, again, only 12% of those who were surveyed spontaneously identified the pregnant population as a risk group at times of extreme heat. So this gets me up in the morning, because I think this needs to change. And hopefully you will agree with me in half an hour. So why is it that we should care in particular for the pregnant population? Well, for those of us who are sort of doing research in the perinatal epidemiological space, anyways, I mean, to us it's obvious, right? Like everyone should care about this. But to state out the obvious, if you have an environmental hazard, such as a heat wave that occurs in pregnancy, of course it can affect, or it might affect pregnancy outcomes, like immediate pregnancy outcomes. It might increase increase the risk of gestational hypertension and preeclampsia. It might increase the onset of early labor and preterm birth, and these will have negative impacts on the mother. But of course, it will also affect the offspring. So it's two generations here that might be affected, and adverse outcomes of the offspring, such as preterm birth and birth defects, might have long-lasting consequences. So preterm birth and birth defects, for instance, are the two most important causes of infant death. And preterm birth, at the population level, those who are born preterm are at greater risk of cardiovascular diseases, infectious diseases, decades into adult life. So we have this full cycle where it can come to a complete cycle at the time that the offspring themselves wants to have children. So in theory, a heat stress at the time of one pregnancy can have direct effects on generations to come. This is in theory, at least. So what are the hypothesized pathways from high ambient temperatures to pregnancy complications. And I say hypothesize because there's very little literature looking at heat exposure and biological pathways of the pregnant population. So we have to sort of steal from other areas. So studies on animals and on non-pregnant populations, etc. But what we do know is that there are several relevant physiological changes that occur during pregnancy. The most obvious, of course, is that there's the fetus with its placenta there, and the fetus will have its metabolic processes. It will generate heat and energy, and it needs to get rid of that heat through the umbilical cord, and it needs to get rid of the waste products. And the placenta, of course, needs a lot of blood as well. So the fetal placental unit demands roughly 10% of the maternal cardiac output. So to accommodate that, the maternal cardiac output increases by 30 to 50% towards the end of pregnancy, which of course puts additional stress to the maternal cardiovascular system. And there are also changes in the maternal core temperature and maternal thermoregulation. So towards the end of pregnancy, the mother is less heat tolerant compared to earlier in pregnancy. So she gets more uncomfortable at the same temperatures compared with outside of pregnancy. And finally, pregnancy is this hypercoagulable state where the risk of thrombosis and blood clots increase in pregnancy in general, and heat stress increase the risk of blood clots. So you can think that the two combined might increase the risk of blood clots even more. And what are the potential biological effects of high ambient temperatures? Well, for one, if the mother isn't able to sufficiently cool down, the maternal core ambient temperatures will increase, which will directly be associated with fetal core temperatures. And from animal studies and from other causes of high fetal core temperatures, such as fever, we know that it is associated with an increased risk of birth defects. We will have a look at the epidemiological literature for ambient temperature in a bit to see whether this is true also for ambient temperature exposure. Dehydration might happen when you're exposed to extreme heat, and when you have dehydration, you might have decreased blood volume, and with decreased blood volume, there might be decreased uterine blood flow, which in turn means less nutrients and less oxygen to the fetus, which in turn can lead to fetal growth restriction. And there's also this thing where when the placenta receives too little blood, it will tend to start secreting prostaglandins. And prostaglandins is one of those hormones that can trigger uterine contractility. And if this happens too early, it's associated with an increased risk of preterm birth. When the mother is warm, or when anyone is warm, we will have a redistribution of our blood flow so that less is to the internal organs, more to the skin, so that we can release all of that extra heat, meaning there might be decreased uterine blood flow. And then this is a very odd thing where we want to sweat when we're warm, right? So we want to produce as little urine as possible. We need it to be as concentrated as possible so that we don't waste fluid to the urine. And in order to do that, we produce and secrete antidiuretic hormone, ADH, which happens to be secreted from the posterior pituitary gland, where also oxytocin is released from. And from non-pregnant populations, we've seen that with ADH release, there's this co-release of oxytocin. We don't know whether that's functional, but it happens. So when during heat stress, it's a tendency of oxytocin release. And oxytocin, for those who've been in labor, know that this is one thing that we give to pregnant women in order to stimulate labor even further, right? Also, with heat stress, there will be a catecholamine release from the adrenal glands. And finally, there's an increase in inflammatory biomarkers, heat shock proteins, and oxidative stress in response to heat stress. So if you found this confusing, you can think that it's intentional in order, like a pedagogical tool and trick for you to think, well, this sure was complicated, and it is, but there's no reason that we should sort of ignore the pregnant population. There are enough plausible biological pathways here that we should be at least interested in evaluating the epidemiological literature of whether there is a link between heat stress and adverse pregnancy outcomes, because there are many things to tag those effects on. So, this is just, I wanted to illustrate one very innovative study that look at actually the biological pathways, because I said that we are learning all of this from the non-pregnant population, but there are few and far between studies, but one of them actually do look at what is the direct biological consequences of heat stress. And this is a study that was conducted in rural parts of the Gambia between 2019 and 2020 of 92 pregnant women, prospectively followed. Heat stress was measured by the hourly wet bulb globe temperature scale. And they used Doppler ultrasound to ascertain the fetal heart rate and also the umbilical artery resistance index. So they measured whether it was fetal strain, if the fetal heart rate was too high or too low, or whether there was inadequate fetal blood flow through the placenta. And this was measured at rest and during working periods. And what they found was that per 1 degree Celsius of ambient temperature, the risk of fetal strain increased by 20%. So with increasing ambient temperature, there was an increase in fetal heart rate. And also, if you looked in isolation at maternal heat strain, regardless of ambient temperature, when the mother experienced heat strain, so did the fetus. So this is sort of a direct study linking exposure to heat stress to fetal strain. And now let's look at the epidemiological literature. So the perinatal period is this period, it even starts before conception, but we're going to focus on from conception to the time of birth, and then you have these outcomes that occur after birth. And the vast majority of the literature is studies that are evaluating outcomes occurring at the time of birth. And length of gestation, or preterm birth, is the single most studied outcome when it comes to heat stress and adverse pregnancy outcomes. So we're going to look at 3 examples of such an association, and 3 studies that use very different approaches. But I think it's illustrative because it shows sort of the breadth of these studies. So in the first example, this was published earlier this year by Wu and colleagues. It's a population-based prospective cohort study in 16 cities in China of women who attempted to become pregnant, and they evaluated roughly 200,000 births, of which 18,000 were preterm. And they evaluated what is the association between ambient temperature the week before birth, or in gestation week 36 for those who gave birth at term, and the risk of preterm birth. They adjusted for some confounding factors. They did not adjust for seasonality or for a year, which I think can bias these results, but let's look at the results anyways. And this figure doesn't look as good on the Windows computer as it does on my Mac, so we're missing parts here. But from 20 degrees Celsius, there is an increased risk of preterm birth. That's what this nonlinear graph shows. And if we're comparing in the week before birth, the 95th ambient temperature percentile compared with the median, we see that there's a 36% increased risk of preterm birth. Now, I said that this study might be subject to some residual confounding, but there was another study published same year, or this year, which also was a prospective cohort study in China. And what they did here is very innovative, and I'm almost a bit mad at them because they did what we had wanted to do. I think this is the first sibling comparison study of ambient temperature exposure. So what they did was that they compared pregnancies or births where the pregnant woman had given birth to 2 children, 2 siblings, and one of them was born preterm and the other was not born preterm, and then they compared what was the ambient temperature the week before birth. And by doing this sibling comparison, you account for a lot of those residual confounding factors that at least are constant within the mother, such as maternal genetic makeup, etc. And they also adjusted for season of conception, which was missing from this previous analysis. And what did they find? They found an odds ratio, which was almost spot on the same as the previous one. So if you compare the 95th ambient temperature percentile compared with the median, there was a 39% increased odds of preterm birth. The confidence interval included the null, but that was because it was a much smaller study. So that was one line of studies. Let's look at another example. This is a case crossover study. Look from Australia. So in a case crossover, you only compare cases to themselves. So you're looking at a hazard period, let's say the day before birth. If that was a Tuesday, you compare that Tuesday to other Tuesdays within the same month. Effectively account for confounding that are constant within this mother. So they looked at 15,000 preterm births. And this figure also does not look as good on the windows. Anyways, they find very much the same pattern of association, so that from 20 degrees Celsius ambient temperature, there is an increased risk of preterm birth. And when comparing the 95th percentile with the median, they find an odds ratio of 1.03, but so the magnitude of association is not as pronounced as previously, which might be because this is a case crossover and not the traditional prospective cohort study analysis. But the significance in terms of p-value, which we of course don't care about, do we? The confidence interval is very narrow, so it's a very significant, statistically significant finding. The final example I'm going to show you is this demographic study. So yet another completely different study design set in the US between 1969 and 1988, evaluating 56 million births. What they did here was that they looked at the birth rates in a given county and looked at whether a high ambient temperature shock was associated with the birth rate in that county on that day and the subsequent days. So they adjusted for county level effects, day of year effects, precipitation, and the surrounding days, the ambient temperature in the surrounding days. So what they effectively did was that in a county, they compared what is the birth rate if this was a hot day compared with other days compared with the same date in other years, while accounting for the trends in birth rates in the US as a whole. And what did they find? They found that on a day of high ambient temperatures with this heat shock, there was an increase in the birth rate. This is for all births, not only preterm births, but for all births. And same for the day after, there's also an increase in the birth rate. But 2 days after, there are fewer births. That's because the births have been shifted, so they're occurring earlier. So you have this heat shock that is triggering labor, just like we saw in the slide of the hypothesized pathways, that there might actually be something to it, right? Okay, so I know what you're thinking. You're thinking, I cherry-picked 3 studies that support my argument that we should pay more attention to the pregnant population. But if we cast our net even wider, let's look at the most recent and robust systematic review on this topic. This is a paper that was published in BMJ in 2020, where they included 70 studies. And this is one of their key findings, which is that when you're experiencing a heat wave, you have a roughly 15 or 16% increased risk of preterm birth. So this is across many studies, across all studies really. And one thing to note, however, is that it's very difficult to compare these studies head to head, let alone to create sort of one aggregate estimate, because these studies have been conducted in so different ways. Like, what is a heat wave? Is it 2 consecutive days? Is it 3 consecutive or 4 consecutive days of high temperatures? Are we looking at the week before birth or the full 3rd trimester, or are we looking at the 2nd gestational week? And also the setting and the underlying susceptibility to preterm birth in these different populations. It's very difficult to compare head to head, but I would say that it's very reassuring that we have all of these different study designs that more or less come to the same conclusion, that there appears to be an association between high ambient temperatures and risk of preterm birth. They also evaluate low birth weight with a roughly 10% increased risk of low birth weight experiencing a heat wave, and roughly a 50% increased risk of stillbirth when you're experiencing a heat wave. And all of the examples I've given before were from studies published after this systematic review was conducted, because the search was ended in 2019. And since then, many studies have been published that generally support these findings. It should also be noted that, as unfortunately is the case for almost all exposure outcome associations that we look at in the perinatal setting, there is racial disparity also here. So when non-Hispanic Black and Hispanic pregnant women are exposed to high ambient temperatures, the associated increased risk of these adverse outcomes, preterm birth, birth weight, and stillbirth, are stronger compared with non-Hispanic white pregnant women. So I would argue that for all of these three outcomes, so length of gestation or preterm birth, birth weight or low birth weight, and stillbirth, there is very robust evidence to suggest that there is an association between high ambient temperatures and these outcomes. And there are other outcomes that have been evaluated as well, one of which is congenital malformations. I put this in italics and a question mark because I wouldn't say that it's sort of definite at this point, but there are certainly studies that do suggest such an association. And for these outcomes that occur earlier, there are several candidates. So some studies suggest a reduced fecundity, meaning a reduced biological ability of conceiving. Several studies indicate an increased risk of miscarriage, increased risk of gestational diabetes, oligohydramnion, so too little amniotic fluid around the fetus, placental abruption, meaning that the placenta detaches from the uterus, preeclampsia, so gestational hypertension in pregnancy. This actually perhaps shouldn't be in italics anymore because there are very many studies suggesting that this association is true. And then severe maternal morbidity, so severe adverse maternal outcomes. And if we're looking at short or long-term outcomes, there are very few studies that directly evaluate the association between ambient temperature and long-term outcomes of the offspring. And I would just like to point out the fact it's also obvious. Everything I'm saying is quite obvious, but because these three outcomes have been robustly associated with ambient temperature exposure, it doesn't mean that these are the ones that are truly the most causally related to ambient temperature. It means that these are the easiest to study. Because how are you going to study risk of miscarriage? Like, miscarriages are very often not even recorded, let alone known about by the woman herself, if they happen very early. So how do you go about studying that? So these are very important outcomes, but it doesn't mean that these are the only ones that are causally related. And the same is true for the long-term outcomes, because how would you go about studying an outcome that occurs years later? Here, you only need birth record data, but it gets more complicated when you're looking at things that happen during pregnancy, and especially things that happen late or like years after pregnancy, which is why we find this particularly intriguing. So this brings us to the final chapter, which is offspring outcomes, which is where my colleagues and I have done some studies, and I'm going to talk about two of them, or some ongoing studies, I would say. So two of the projects I'm going to talk about are childhood acute lymphoblastic leukemia, and the other is cerebral palsy. I'm going to spend the most time talking about this outcome, because this has come the furthest, but I'll also very briefly mention this one. So childhood acute lymphoblastic leukemia is the most common childhood cancer. Luckily, it has a fantastic 5-year survival rate, but the incidence rate has increased over the last decades for reasons that are unknown, largely. And it affects Hispanic children more than non-Hispanic children, also for reasons that we don't really know. This figure also looks a bit odd on this computer, but anyways, this is attempting to show that the incidence, the age of onset, or the age when the disease is recognized, is typically at 5 years or earlier. So this is the preprint for the study that I'm going to talk about. So this has been submitted to a journal, and out of respect for the journal and the editors and the reviewers, I'm not going to talk about anything related to the review process. I'm only going to talk about things that are publicly available in this preprint. And I also want to flag or to mention that this work was made possible by the collaboration with this really fantastic team of researchers. And I feel like we often do say that this has been like a collaborative approach, etc. But this has particularly been true in this project because we come at this question from very different backgrounds. So my background is in clinical medicine, perinatal epidemiology. But then on this team, we have climate change and health researchers, environmental epidemiologists, cancer epidemiologists, biostatisticians, and it's really been a huge learning opportunity for me as well to work with these researchers, many of which are here at Yale. So for this project, we received funding from the Yale Center on Climate Change and Health, the Climate Change and Health Research Program, which really made it possible for us to kick off this project. And I have received funding through the YCCI, where I've received like a YCCI Scholar Award, which is this sort of backdoor opportunity to get NIH funding for those of us who are immigrants and not eligible for a K award. So shout out to the YCCI program. So that's a fantastic opportunity. And for the background on this project, we know that childhood leukemia has a prenatal onset. And we know this because if we're looking at the blood spots at the time of birth of children who are later diagnosed with childhood leukemia, many, if not most, have pre-leukemic clones at the time of birth. So this means that the disease onset starts in fetal life. We know that oxidative stress may cause pre-leukemic clones. It's been suspected, at least. And we also know from the non-pregnant population that high ambient temperatures may increase oxidative stress. In terms of timing, we know that lymphopoiesis starts around gestation week 8. So acute lymphoblastic leukemia stems from the lymphocytes. And there's this general rule in perinatal epidemiology that the period when the tissue is the most vulnerable is the period when it's also the most immature. So it's reasonable to expect that the tissue relevant for childhood leukemia is most vulnerable around gestation week 8. That's our hypothesis. And sort of supporting that hypothesis is epidemiological studies showing that children with childhood leukemia are more likely to be born in late winter, which can have all sorts of causes why there is such an association. But one of those can be that they're exposed to high ambient temperatures in early pregnancy. And we also know that air pollution in early pregnancy is associated with an increased risk of childhood leukemia. And finally, we know that all sorts of other stressors, such as infections, are associated with an increased risk of childhood cancer. So this is sort of why we wanted to evaluate this particular association. And our research question was, is there an association between high ambient temperature during pregnancy and risk of childhood acute lymphoblastic leukemia? And this is the hypothesized association. So we anticipated, or we hypothesized, that the per unit increase in ambient temperature, the greatest magnitude of the association would be around gestational week 8 to 12, for the reasons that I talked about earlier. And we also included this pre-pregnancy period because we didn't expect there to be any direct effect of heat exposure prior to conception because the tissue doesn't yet exist. We can talk about at length other reasons why there actually might be a pre-pregnancy effect, but we hypothesized that there wouldn't be an important pre-pregnancy effect. So what did we do? We used data from the CalSec study, so the California Linkage Study of Early Onset Cancers, which has birth records from California between 1982 and 2015, linked to the California Cancer Registry from 88 to 2015. And we matched cases to controls by a 1 to 50 ratio, matched on last menstrual period, race, ethnicity, and sex. And the reason why we matched on date of LMP, so LMP is sort of what tells us when conception occurs, because it on average occurs 2 weeks later. We don't know when conception occurs, but we do know when LMP happens. So by matching on date of LMP, we made sure that the cases and the matched controls were pregnant at the same stage of pregnancy at the same time. So this yielded 6,258 leukemia cases and 300,000 controls, making it one of the biggest studies on leukemia. And for exposure ascertainment, we used ambient temperature estimated on a 1 kilometer grid. And we adjusted for key confounders in addition to the matching factors. And we ran the analysis in 2 steps. So in the first step, we conducted conditional logistic regression, evaluating each week individually. And then we created these smooth curves between the weeks by using this Bayesian meta-regression method. And because we're only interested in high ambient temperatures, we only considered the warm season. So the gestational week had to occur between May and September. So remember, this is the hypothesized association before we had any of the temperature data, before we had run any of the analysis. And these are our results, which I would say look very much like the hypothesized association. So we were very happy with this, where we found, just as hypothesized, that the peak, the greatest magnitude of association was in gestational week 8. So for every 5 degrees Celsius increase in ambient temperature, or every 10 Fahrenheit increase, there was an associated 7% increased risk of childhood leukemia. So focusing more on that gestational week 8, which was the peak of this curve, we did sub-analysis. And so in the stratified analysis by Latino or non-Latino white, we did expect there to be a slightly stronger magnitude of association for the Latino pregnancies and offspring, because Latino children have the greatest burden of childhood leukemia. And other literature has suggested that Latino pregnant women are more exposed to high ambient temperatures compared with non-Latino white pregnant women. And there was a tendency of a greater effect, but it was not significant. When we did sub-analysis based on the age of diagnosis, we see that there was no association for the late onset childhood cancers, which sort of makes sense because those late onset childhood cancers are on average less likely to have this prenatal onset. We also did non-linear analysis in gestational week 8, which we had hypothesized we would have sort of this hockey stick association, but this is fairly linear, really, and the confidence intervals are very wide. And then we did a secondary matched analysis or a sensitivity analysis, because when we matched on LMP, we sort of made sure that the cases and controls were pregnant in the same stage at the same time. So in order for there to be exposure contrast between them, they had to live at different locations. So here were location A, let's say Sacramento, and location B, San Diego. So they had to be pregnant in the same gestational stage at the same time, but living in different places in California. But for our sensitivity analysis, we wanted to check, because there might be other differences between Sacramento and San Diego than just temperature. So we wanted to do a sensitivity analysis where we matched on LMP occurring within 365 days, so within a year, but that they lived within 10 kilometers of one another. So thereby ensuring that they lived at the same place, they were pregnant within the same year, but exposure contrast. So now we're comparing those living in San Diego to one another, but being pregnant at the same gestational stage, but at different times within that same year. Thus inducing all sorts of bias due to seasonality. So by design, we're doing that. But this was a sensitivity analysis, and what we found was this, where we again see this positive association in early pregnancy and risk of childhood leukemia. And by design, if the cases are more likely to be in gestational week 2 in July, they are necessarily need to be in gestational week 25 in December. 6 months later, you will have this sort of biased other directional effect. But these were the findings from this study. And finally, I would like to mention the other project that we have ongoing on the risk of cerebral palsy. Also, here we have received funding from the Yale Planetary Solutions Project. And again, I'm just going to talk about what is already publicly available, but we've put together a fantastic team of researchers here at Yale. And what we know is that cerebral palsy is the most common neuromotor condition in childhood. Inflammation in pregnancy tend to increase the risk of cerebral palsy. And heat stress increases the risk of increases inflammatory biomarkers. We know that high ambient temperatures in pregnancies are associated with impaired fetal head growth, and impaired fetal head growth in turn is associated with neurocognitive delays. And finally, preterm birth is the most important risk factor for cerebral palsy. And as we have established, high ambient temperatures is likely associated with an increased risk of preterm birth. So what we're doing in this study is that we are looking at children with cerebral palsy in California born between 2000 and 2015, roughly 10,000, and compare them to a 20% random sample of the birth cohort within those same years, so roughly 1.6 million. And we're going to do traditional observational analysis, and we're also going to do a sibling comparison. And at the time that we pitched this project, we thought it was the first sibling comparison study, but I've shown you the first. So this will probably be the second or third, or I don't know, 5th or 10th at the time that they reach this publication. So, so we're very excited about this project as well, and hopefully we'll get going with the analysis within not too long. So, some concluding remarks towards the end. I argue that the pregnant population is vulnerable during periods of high ambient temperatures, and I think this is underappreciated, and I think that policies and public health recommendations and clinical recommendations need to acknowledge that the pregnant population is vulnerable during heat waves. And I argue that we should suspect that there might be an association between exposure to high ambient temperatures in pregnancy and long-term offspring outcomes. This has not yet been robustly established, but I think we should look into it, and I hypothesize that there is such a link. So in terms of the research gaps, this is one of the research gaps. I think that we need to look at the long-term outcomes for the offspring for being exposed to high ambient temperatures in pregnancy. I'm not only saying that because this is where we're doing research and we need funding, but I actually do think so. And we also need to establish what are the pathways between heat stress in pregnancy and adverse pregnancy outcomes. We need to establish what is the threshold for safe and unsafe individual level exposure to high ambient temperatures. And finally, because the heat waves aren't going away, we need to know how we can protect the pregnant population for them and for future generations. So with that, I thank you for your attention, and I would be happy to answer any questions.
So due to the time limitation, let's take 2 minutes. Yeah.
I was wondering if you saw any changes in how, like, if maternal age impacted whether they were susceptible to extreme heat during pregnancy, or if there are any other factors that influenced how heat impacted the pregnancy.
That's a really cool point. We actually didn't, so we adjusted for maternal age, and maternal and paternal age are risk factors for childhood leukemia. So that's actually a very good point, but we didn't. But yeah, that would be interesting to look at. Sure. Oh, there's something in the chat. Yes, so great questions. So we want to stratify by other racial and ethnic groups, but because childhood cancer is, fortunately enough, it's not super common, and it's most common among Hispanic or Latino. So we only had power to look at Latino and non-Latino white, and there were very few Black children with childhood leukemia. So we weren't able to look at that. And in terms of socioeconomic factors, that's also a great point. We could, in theory, do a stratified analysis based on socioeconomic indicators. We have educational level, and we have sort of neighborhood level as well. So that is something we definitely could consider, but we actually didn't do it. We felt like we were doing a lot of analysis, so we wanted to restrict ourselves a bit, but yeah, that's a great suggestion.
There's another one on the first.
On the first one, yeah.
Yeah.
Yeah, the mechanisms linking high temperature during pregnancy and high risk to childhood leukemia. That's the $1 million question. Of course, we don't really know exactly what those mechanisms would be, which is the case for all of these adverse pregnancy outcomes, by the way. We don't know why heat stress causes or is associated with increased risk of preterm birth. We do suspect several mechanisms, but we don't know it yet. And the same is true for childhood leukemia. We don't know exactly why, but the reason why we were interested in it to study it was for those reasons that I talked about in those previous slides, that we know that other environmental hazards in pregnancy are linked to it. We know that it has this prenatal onset. And we know that, for instance, one potential biological pathway is that heat stress in the non-pregnant population increases oxidative stress. And some studies have suggested that oxidative stress can induce the production of pre-leukemic clones. But we don't know whether this is the mechanism here. But I can say as much as this is something that we are interested in looking at further.
So let's say another question, but due to the time limitation, let's make this the final question from the Q&A.
Okay, thank you. Mike Bracken. Yes, great question. Thank you, Mike Bracken. For our project, we haven't looked at access to air conditioning. I think that's very interesting for this. For any pregnancy complications, really, it's an interesting question to look at risk mitigation. But I do want to show you, because you asked, actually do have a bonus slide. I have so, like this presentation initially lasted 1.5 hours. So you're lucky to get off early enough. But let's see here. I do have a slide on that I took out this morning. Here. So as you can see here, this is looking at the effects of high ambient. This is the demographic study from the US, looking at those 56 million births. The effects of high minimum temperatures, high minimum daily temperatures, so that's reflecting more the nighttime temperature, increases the risk or increases the birth rate on that day and the consecutive days. But if we model that the pregnant population or the population have full access to air conditioning, which they could do in the study because there was a very large increase in the access of air conditioning units, so they could actually model that. There would be a reduction by 3/4 of the induced birth rate. So, yes, I think that access to air conditioning is one of those factors that actually can modulate the association between high temperatures and adverse outcomes.
Right. I think we are at the end of the seminar. Thank you so much. Joining us in person or on Zoom. Thank you.